Okay, guys, we're going to look at how we interpret oxygenation, specifically when we're looking at alveolar oxygen versus arterial oxygen. So the first thing I want to talk about is the AA gradient and the AA ratio. So we talked a little bit about how because of VQ mismatch and regional differences in the lungs, the amount of oxygen that we have in our lungs never fully diffuses into our arteries. So we call that the AA gradient. So we're looking at the pressure of alveolar oxygen compared to the pressure of arterial oxygen. Okay, and there's always going to be a normal difference there, but if that difference starts to get to be too large, then we're concerned about an increased VQ mismatch. So we always have a normal level of VQ mismatch because of that anatomical dead space and that anatomical shunt. Usually it's anywhere between 5 to 10, but if you start to get a wider difference, then we're going to be concerned about an increased VQ mismatch. If by any chance you worked ahead and had already listened to my recording or already looked through the PowerPoint, I made just some small changes here. I went through the board review because I wanted to know what the new updated version of the AA gradient was. And the normal value for the AA gradient is approximately the FiO2 that you're on. So if a patient is on room air, then they tend to think that a normal AA gradient is up to 20. If you are on 40%, then your AA gradient would be about 40. If you're on 80%, about 80. So the normal value is approximately the FiO2 that you're on. It's always going to be a positive number because your alveolar oxygen is always going to be higher than your arterial oxygen. And when you think about the fact that you have this alveolar oxygen in your lungs that's diffusing into your bloodstream, there's just a gap there. Not all of it is getting in. The second thing that we're going to look at to see if we have an increased VQ mismatch is an AA ratio. And that's taking the same two numbers but in a little bit of a different way. So here we're going to take our arterial oxygen and we're going to divide it by our alveolar oxygen. This is always going to be less than 1, and the reason it's always going to be less than 1 is your arterial oxygen level is always going to be lower than your alveolar oxygen level. And again, this happens in the healthiest of people because we have that anatomic dead space and that anatomic shunt. Now, when you have things that increase this difference, like for example, having an alveolar dead space, increased alveolar dead space or increased alveolar shunt, then you're going to start to see this become a different scenario. So the normal value is around 90% for this. If you add 60%, that's going to tell you that your arterial oxygen is much lower than it should be given the pressure of alveolar oxygen that you have. So these are direct comparisons of the pressure of oxygen in your lungs versus the pressure of oxygen in your arteries. Okay, and we're going to look at it to see if we have an increased VQ mismatch. When we're looking at hypoxemia, there's a couple of different ways that we classify it. One way that we're going to do with our arterial blood gas analysis is to classify it as no hypoxemia, mild hypoxemia, moderate hypoxemia, and severe hypoxemia. And you can look at the ranges that are associated with those, and these definitely need to get on a flashcard, and you guys need to memorize this. This is something that you're going to use over and over and over again. The other thing that you sometimes see is something called hyperoxemia or overcorrected, they'll sometimes call it, which is where you have a higher than 100 PaO2. This only happens when you're on supplemental oxygen, okay? So sometimes you'll see like a PaO2 of 120. That's only going to happen when you're on supplemental oxygen. You're not going to have a high arterial oxygen above 100 when you're on room air. So these ranges, definitely memorize them. Know if they are no hypoxemia, mild hypoxemia, moderate hypoxemia, or severe hypoxemia. One thing I want to draw your guys' attention to for like clinical practice is currently the way that we're solving for our alveolar oxygen is with the alveolar air equation. When you're in a clinical setting, a lot of times you don't have time to bust out an equation and do the math. So kind of a good predictive level is if you take your FiO2 times 5, that gives you your approximate alveolar oxygen number. So if you're on room air, you can take 21 times 5, it's around 100. If you're on 40%, 40 times 5 is about 200. 100%, 100 times 5 is around 500. So where this comes in handy, sorry, I'm getting click happy. Where this comes in handy is, let's say you're on 40% oxygen and you know that you should have an arterial blood content around 160 to 180 because you know that this is 200. So you expect a little bit of a difference, but you shouldn't see more than about a 40 millimeter of mercury difference. If, let's say, you're expecting anywhere between 160 and 180 for this number because you did this prediction and you actually have an arterial blood content of 70, you're going to recognize that that's way worse than if it was 70 on room air, okay? Because here you're on 40%. So you know that your difference between your alveolar oxygen and your arterial oxygen is way larger in that example than it would be in, let's say, this example where it should just be 100. That's where this comes in handy. The higher your alveolar oxygen, the higher your arterial oxygen should be. And so if you kind of know about what to expect, it helps you to know how poorly that patient is oxygenating. And that can give you a lot of clues as to how bad the VQ mismatch is, if that patient is shunting, how aggressive you need to be with the treatment of that patient. So we talked about analyzing hypoxemias or classifying hypoxemias as no hypoxemia, mild, moderate, and severe. The other way, and I want you to be really careful with the wording on this, is we have to classify hypoxias, okay? So hypoxemia is your no, mild, moderate, severe. Hypoxia is going to be hypoxemic hypoxia, hemic hypoxia, circulatory hypoxia, or histotoxic hypoxia. So this is a little bit different. The other one is more numbers based. We are classifying it as no, mild, moderate, or severe. You're not differentiating what's causing the hypoxia. This, you're actually going to go back through and figure out what is causing the hypoxia of your patient. So if it's hypoxemic hypoxia, this is where you have some sort of difficulty getting the O2 through the lungs into the blood. So this can be a diffusion issue, something associated with Fick's law. And you're going to have a low arterial oxygen pressure. So that's kind of like the general overarching explanation of the hypoxemic hypoxia. Hemic hypoxia is where you're going to have decreased O2 carrying capacity. So it's going to be a problem with the buses. Either you don't have enough buses, you have a low hemoglobin, or you have a low saturation, which means that the buses aren't filled with passengers like they should be. Something's going on with the ability to carry the oxygen. So you might be diffusing it, but now you can't carry it. The third type of hypoxia is circulatory. That's where you have a problem with the transport system. So maybe you're diffusing okay, and maybe you have buses and they're picking it up okay, but you don't have enough cardiac output or blood pressure to take those buses where they need to go. The last one is histotoxic. This one is pretty rare in its application, but what this is an example of is if you have okay diffusion, you have plenty of buses and they're all full, they're transporting around okay, but then when they get to your cells, for some reason, your cells are not able to extract that oxygen. They're not able to use it, and there's a couple reasons that can happen. So we'll start at the beginning with the hypoxemic hypoxia. Again, this is more of a diffusion issue. You're having a hard time getting the O2 from the lungs into the blood, and it's causing a low arterial oxygen. So the three things that we're going to look at is hypoventilation. If you see a high PaCO2 and a low PaO2, then you have hypoxemic hypoxia caused by hypoventilation. If you see an increased VQ mismatch, and we're going to do two mathematical things for that. You're going to do your increased, if you have an increased AA gradient, and we said the normal is about the FiO2 that they're on, or a decreased AA ratio, then we would say they have hypoxemic hypoxia because of an increased VQ mismatch. The third thing that we're going to look at is if they have hypoxemic hypoxia, you can solve to see if they have a shunt. And a shunt is perfusion without ventilation. And there's a couple of mathematical ways that you can figure out if they have a shunt. So this is just kind of a reminder of what VQ mismatches look like. This is an example of shunting right here because you have perfusion without ventilation. You can see these alveoli are not inflated properly. These are the mathematical ways that you will determine if you have a shunt for hypoxemic hypoxia. So the 50-50 rule, if your arterial oxygen is less than 50, sorry that's torr, it should be millimeters of mercury. They mean the same thing, but I just probably didn't switch that over. If your PaO2 is less than 50 and you're on a supplemental FiO2 of greater than 50, you have a shunt. And what that means is even though you have oxygen coming in, for some reason it's not raising your PaO2, which means your VQ mismatch is so bad that you're actually having shunting. There's no ventilation available for that. If you have a PF ratio of less than 200, and what a PF ratio is just taking your arterial oxygen content divided by your FiO2 that you're on, and use the FiO2 in a decimal form, and if it's less than 200, you have a shunt. The other way that we can determine if we have a shunt is if you take your AA gradient, right, which we know how to solve for, that's your alveolar pressure of oxygen minus your arterial pressure of oxygen, and you divide it by 20. If that is greater than 5%, then you have a shunt, okay? So that's how we're going to decide that. So this is a little bit of a decision tree for hypoxemic hypoxia. So the first thing you can look at is your PaCO2 increased? If yes, then you're talking about hypoventilation for your hypoxemic hypoxia. If no, you're going to look at your FiO2 and your barometric pressure equations, your alveolar air equation. So down here, you're going to look at AA gradient increased. If it's above what it normally should be, then now you've realized that you have a VQ mismatch. Does it respond to O2 therapy? So you realize you have this VQ mismatch, you increase the oxygen. If yes, it responds to the oxygen therapy, then you just have a VQ mismatch. If it does not seem to be responding to the O2 therapy, then you have a shunt. And the reason why is if you truly have a shunt where you have perfusion without ventilation, you can give them more and more oxygen to try to increase that diffusion gradient. But if they don't have ventilation, it doesn't matter. They're still going to have that low PaO2, and that would be the shunt that we're talking about. For hemic hypoxia, this is a different component. So let's say you're diffusing oxygen from your lungs into your bloodstream just fine, but when it gets into your bloodstream, there's no hemoglobin to pick it up. Or there's hemoglobin, but for some reason they can't get full of passengers, okay? Or the hemoglobin are filled with other passengers. This is hemic hypoxia. So it really has to do with your hemoglobin and the ability to carry oxygen. So some of the things that can happen is having the lack of hemoglobin, which is anemia. So that just means you don't have buses to carry it at all. Carbon monoxide poisoning, or they call that CO hemoglobin. And that's when your hemoglobin are filled with carbon monoxide. So I'm going to take a minute to talk a little bit about carbon monoxide poisoning. So be very, very careful that you don't confuse CO with CO2. So CO2 is carbon dioxide. That's the gas that we naturally and normally exhale. Carbon monoxide is CO, so just one oxygen molecule. And it's a byproduct of fossil fuels that burning, wood burning stoves, car exhaust. There's a lot of things that can cause carbon monoxide. But the reason that we as respiratory therapists are concerned about carbon monoxide is carbon monoxide has, I think it's 200 times more affinity for hemoglobin than oxygen. So when CO binds to hemoglobin, it does not want to come back off again. So what happens for patients that have carbon monoxide poisoning is this carbon monoxide binds to their hemoglobins. It will not come back off. So then the carbon monoxide cannot pick up any oxygen molecules. And so you basically suffocate. It's tricky to diagnose as well, because when you think about a patient that comes in to the emergency room, generally speaking, we check an SpO2, which is like an indirect measurement of their oxygenation. So you put the finger probe on, and what that's measuring is it's measuring how full the hemoglobin are. It doesn't measure what's on the hemoglobin. So this patient will be saturating 100%. Their skin will be pink. They won't be cyanotic because their hemoglobin are full. They're just not full with oxygen molecules. And so then the way that we figure out that they have carbon monoxide poisoning is usually through patient history. For example, we had a patient that came in that was working in his garage. He had a fire burning stove in his garage and hadn't properly ventilated it. He came in because he was feeling nauseous and he was talking about what he had been doing. So then we knew he was at risk for carbon monoxide poisoning. We drew a blood gas, which actually gives you a carboxy hemoglobin level. And what you have to do to treat them is, depending on how high of a level it is, you put them on 100% oxygen. And the reason that 100% oxygen will help is you increase the diffusion gradient so much by putting them on such a high level of oxygen that it finally forces that carbon monoxide off the hemoglobin. Or if they're bad enough, we actually will put them in a hyperbaric oxygen chamber. And we do that because you need a high pressure of oxygen to actually lodge off, like knock off those CO molecules. So carbon monoxide poisoning would be considered a hemic hypoxia because it basically takes up all the seats on your buses and it does not let oxygen get on. And so the patient will suffocate that way. If you have an abnormal hemoglobin, so there's met hemoglobin, which I'm not going to go into the details of met hemoglobin right now, but it's a rare reaction that can happen sometimes with lidocaine or benzocaine that can make it where hemoglobin can't utilize oxygen. Sickle cell, which is you probably have heard of sickle cell anemia, but it's where the shape of your hemoglobin is not normal and it limits its ability to bind oxygen because it doesn't have the proper configuration. So that can make it more difficult for you to carry as many oxygen molecules. And then if you have a shift in your oxyhemoglobin dissociation curve where it changes your affinity for oxygen, so we talked about that, how if it shifts to the right, the hemoglobin's affinity for oxygen goes down, so then it's less likely to want to carry oxygen. So some things that can happen with that is if somebody has a respiratory or metabolic acidosis, it makes the hemoglobin not want to pick up as much oxygen. So this kind of hypoxia is because you don't have the ability to carry oxygen. So your buses either are limited or they don't want to pick up oxygen like they should. So this is just a reminder of the impact of the number of hemoglobin. So if you go from 15 to 10 to 5, if you do your CaO2 equation, you can really see the difference in oxygenation. So this is just me reminding you of what a large impact hemoglobin has on your O2 carrying capacity. It's really like the big way that oxygen is transported. So just circling back to what we already talked about in previous units. The third hypoxia we are going to talk about is circulatory hypoxia. So this is, let's say your diffusion is good, the oxygen's moving from your lungs into your bloodstream, no problem, nothing's going on in a fixed law sense. Your buses are there, all the passengers are loading on okay, and now there's no roads. Something is going on with the transport system. So this would be a situation where you have low cardiac output, or it could be where you have really low blood pressure. And I always remember cardiac output because it kind of reminds me of minute ventilation. If you take heart rate times stroke volume, that is cardiac output. It kind of reminds me of the respiratory rate times tidal volume. But the normal is 5 liters per minute. So things that can affect cardiac output are any sort of issues with your heart can affect how much blood it puts out because it's a pump. If you have a lot of blood loss, that can affect it. If you have low blood pressure, that can affect it. So anything that's going to affect the ability for blood to circulate through your body is going to potentially create a hypoxia. So this would be, again, the diffusion's not an issue. Blood is going from the lungs into your bloodstream. There's buses there to pick it up. They're full, but now they don't have any roads to travel all throughout your body. So that's causing a different version of hypoxia. So that's your third kind of hypoxia. The fourth and the very limited hypoxia that we're going to talk about is histotoxic hypoxia. And what this would be is if your diffusion is fine, so the oxygen is going from your lungs into your bloodstream, there's buses to pick it up, the buses are fully loaded, the roads are fine, you have good cardiac output to transfer the oxygen around your body, but for some reason the cells in your tissues are unable to utilize the oxygen. And what this is a low O2 extraction ratio. There's actually math involved in this. I'm not going to make you guys learn the math, but your cells have to be able to take up those oxygen molecules and use them in a metabolic process. A histotoxic hypoxia is a situation where the cells in your tissues can't extract the oxygen from your blood and they can't use it. Some things that can cause that, if you overdose on Tylenol, this can cause a situation where temporarily your cells cannot utilize oxygen. The other way that you guys will see on the boards that they like to ask is if you have cyanide poisoning. The reason that there's a picture of peaches over here is I remember when I was in respiratory school, the story that my professor had told me was that there was a woman who was married that was trying to slowly poison her husband, so she kept grinding peach pits because peach pits, well, a lot of fruit seeds and pits have trace amounts of cyanide in it, and she must have read this, and so she was grinding them and trying to poison her husband with cyanide. The issue is with peach pits or other fruits, it's a very, very low amount, so she was not successful. But it's for that story just always really stuck in my head, and so I'm sharing it because I feel like anytime you can make these like random linkages to help facts stick in your head, it always helps. But histotoxic hypoxia is either cyanide poisoning or an overdose of Tylenol can cause this. And what this is your cells are not able to use the oxygen in your bloodstream. They're not able to extract it. So that's the fourth type of hypoxia that you guys need to know. This is just a little decision tree that I made to help you guys kind of categorize it in a short way. So you have hypoxias. Your first one is hypoxemic. So you're going to look at hypoventilation. You would have to have a high CO2 for that. VQ mismatch, that's where you're going to use your AA gradient and your AA ratio to try to decide if that's an increased VQ mismatch. The third thing that we're going to look at, if this is true, is the VQ mismatch so bad that they're actually shunting? And there's three math equations that we talked about for that. The 50-50 rule, the PF ratio less than 200, and the AA gradient divided by 20 being greater than 5. That's how you know if you have a shunt. Then you can come over to the hemic hypoxia. This is going to be a problem with your buses. So anemia, which is where you don't have enough buses, abnormal buses where they can't pick up the passengers like they should, or if you have a right shift in your curve and for whatever reason your hemoglobin don't have the same affinity for oxygen that they should, like in the example of an acidosis. The third hypoxia is that circulatory hypoxia. So that's going to be a problem with the roads. So think heart, vessels, cardiac output, blood pressure, that kind of thing. Histotoxic is that cyanide poisoning or overdose of Tylenol, and it's where your cells can't actually extract the oxygen from your bloodstream. So for a patient case scenario, I could say classify the hypoxia, and you'll know what I'm talking about if it's hypoxia. You're going to know that I want one of these. If I say hypoxemia, that's the mild, moderate, severe. So if I have you classify the hypoxia, this is what I'm talking about. Now, a patient can have more than one type of hypoxia. If you have a patient that's in a motor vehicle accident that has a lot of potential blood loss, they could have hemic hypoxia because they have low hemoglobin. They could also have circulatory hypoxia because they have low cardiac output from the blood loss. You can put both, or if you pick one, if I'm only asking for one, just make sure that your reason why is accurate. If you put that the patient has hemic hypoxia and then you cite their low cardiac output as the reason why, I'm going to mark that wrong. If you're going to do hemic, I want you to talk about the hemoglobin. If you're going to do circulatory, I want you to talk about the cardiac output. So even if a patient has more than one hypoxia, make sure that you're describing it correctly, and that's how you'll get the full points. These are your lecture questions. If you guys have any additional questions, always feel free to email me. And that is it for that one.